So our next speaker is Erica Pitch, and she has a doctorate in physical therapy and an NCS certificate, which stands for Neurologic Certified Specialist. And that's the kind of specialist that you want to see if you have a movement disorder or some neurological disorder and you're looking for a physical therapist. She's actually heard of PSP, CBD, MSA, and DLB, so that sets her apart as well. And she is at UC San Francisco School of Physical Therapy and Rehabilitation Science, and she will be speaking today on movement, balance, and exercise in atypical Parkinsonism syndromes. And again, we don't have the two projectors going. That was our mistake, and hopefully they'll get going in a few minutes, right, Denise? Yes, okay. But the presentation for Dr. Pitch is in your packet. So thanks very much for coming, Dr. Pitch.
Whoops. Is this on yet? Is this okay? Okay, good. I was really worried because trying to talk about movement from behind a podium would have been a big problem. So glad this worked out. And thank you so much, Robin, for having me. It's just this, I really appreciate this opportunity. And also in our PSP breakout session, we had Phil Meyer talk about the 8 things you need to know about PSP. And number 4 was exercise. Exercise, exercise. So I couldn't have asked for a better segue into this talk. And Robin was really great because she also asked for very, very specific things that I would talk about today. And so what I'm going to talk about are movement and its unique challenges of movement with this category of neurologic problem. We're going to talk about balance and falls, both how to prevent them and what to do in case you have one. And then also, toward the end, when food coma is really kicking in, I'm going to get you moving. All right? That's why they put me here. So I can be like the cheerleader and get you guys going. So first of all, I wanted to explain where we come from in rehab and the strategies we use with any problem. There's usually 3 prongs. We talk about prevention, compensation, and recovery. And now compensation is the pretty easy one. That's doing something, either a habit, a behavior. No, we have no projector. Okay. All right. Well, while we're waiting for that to wake up, compensation. Okay, quick. Okay, compensation. That's when you use something else to cover for an ability that's lost. For example, if you're having trouble balancing, you may use a cane or a walker, or if walking gets really difficult, using a wheelchair in order to accomplish the task of getting from point A to point B. So that's compensation. That's a pretty straightforward one. Prevention, this is where we really live, especially with these kinds of diagnoses, because we're not only trying to prevent falls and adverse consequences of the disease, but the big thing is that with a disease like this, people have one fall and their confidence is shot. They have trouble moving, and so they decide not to do those things they like doing anymore. They say, I don't go walking because it's hard. So then if you stop doing things, bodies are hungry and lazy. So if you don't use a muscle, it leaves. We all know that. You've seen athletes, they get injured and what happened, I don't know if any of you ever been in a cast? Yeah? What'd your limb look like when the cast came off? It's tiny, yeah. So if you don't use it, it leaves. This happens to muscles. This happens to heart function. This happens to bone. So not only does the PSP and all these diagnoses are in the brain, but by not moving, it can affect your other systems. And we call that as secondary causes, or what we will look at is secondary prevention. How can we prevent those secondary problems? Now we look at recovery and compensation and preservation. With these problems, we're not going to get rid of the tau protein. We're not going to change those neurofibrillary tangles. So we can't do much about the pathophysiology of the disease, but preservation. If you can move it, you can use it. Again, research hasn't stood up to the fact that research hasn't proven that we can extend the life of any of these illnesses with exercise, but anecdotally, we see it. And Phil's nodding his head. What he said is his wife's physician told them that they bought her a year of extra time, of extra life from working on the treadmill every single day. So it's exercise and intensity. Okay, so here's that list again of things you can avoid by keeping moving. Avoid decreased cardiovascular conditioning, decreased strength, increased stiffness, all these things from just choosing not to move. Any of us, neurologic disease or not, you sit still, lie in bed for a really long time, these things happen, right? Also, as we heard in our previous speaker, increased risk of pneumonia, blood clots, skin breakdown, and even falls. Just from getting weaker, you can increase the likelihood of falling. Okay, but what we know from Parkinson's, that's the group that studied more because there are just more of them, we know is that balance programs do work at improving physical function, improving walking speed, improving measures of can you stand up, turn around, sit down as quickly as you can. Those things improve. So far, we haven't proven that we can reduce the incidence of falls. The other important thing about this, and these are both like big review papers, so not just like one study, but a bunch of studies that they put all together, rate them for quality, and then decide what's the main effect. What they found here is that the more challenging the program, the more sweat, the more intensity, the better they did. Okay? And if you look at physical therapy compared to nothing, they do better. So, got to do something. Now, we know that the more mobility you have, the use it or lose it principle, if you have more to use, you can keep that. So this is much easier to do rehab, much easier to exercise in the very early stages of the disease. The uncomfortable truth, and this is the part that is really difficult for family members, for patients, for everyone involved, is that those balance problems, especially with PSP or any of these disorders, I haven't found that magic trick, that tool. Many of you may have worked with PTs. We can be pretty much MacGyvers about things. We can be pretty creative and make things up about how to solve a problem. I haven't been able to solve this problem. So I can't stop those sudden losses of balance. Yeah, we deal with a lot in our profession. The only time I ever cried in front of a patient was when I had, you bond with certain care providers more than others. This lady and I loved our sci-fi, and she was reading an obscure author right when we met, so we connected right away. She came into the clinic with a rollator and a black eye. I had nothing. She was falling so frequently, and all my tricks didn't work. So things like that, which really, that's where you go towards compensation. That's where you go towards using the walker, and maybe if necessary, a wheelchair. And that's a tough decision for everyone to make, but make it before you have that big fall. You just gotta try to keep moving. Now, the other challenges are the cognitive deficits, right? The initiation, the motivation. I mean, it's hard for all of us. Family members, how often do you exercise? Right? It's hard. It's hard to get out and exercise. And when you have a motivation problem, an initiation problem, it's even harder, right? Or even remembering to use that walker, use that assistive device. Ways to get around this are set it up, repetition. Using that practice, establishing a routine. Keep the walker in front of them. Those little reminders, chair alarms. Put something in the seat that when they get up, it'll go off and alert you that they may be getting up and not being safe. But here's the other thing too. There's one of those big old review papers on people with Alzheimer's, because again, there's not enough big review papers for the problems we're dealing with. But people with dementia, they respond to exercise too. What do you think? You think harder is better here too? Harder is better. As long as it's safe, harder is better. Challenge is good as long as it's safe. Okay, so getting a little bit on prevention, and I'm touching on a lot of these topics. I could spend an hour on fall prevention in the environment or reducing risk hazards. I could spend an hour on exercise. So I'm going to be going through this pretty quickly. I apologize. But first, so a lot of falls can be prevented just by changing your environment, right? So really quickly, over on this side, shout out fall hazards in the home. Rugs! Throw rugs, the worst. What else? Stairs. Just stuff. Yeah, stuff on the floor, right? Dog toys, electrical cords, animals, exactly. Okay, center aisle, in your yard, in your immediate environment, like outside your home. Stairs, yep. The hose. Uneven ground, yeah, exactly. The garden out there, weeds. Okay, how about outside, like in the shopping mall? People, yes, other shoppers, people driving their carts. Yeah, exactly, not paying attention. Cars backing out of, those bumps in the sidewalk. Children, yeah, all these things everywhere is a tripping hazard. That's why we have duct tape on the cords right here. Right, so it's really important to be aware of those hazards in your home. Also think about lighting. Lighting's a big one because we use 3 senses for balance, right? You use the sensation in your feet, your joint position sensors. You use your inner bubble level, your vestibular system that tells you where up is, and you use your eyes. Well, if you're having trouble with balance, you got to use everything you have. You got to augment the input. So if you're walking in the dark, nobody's balance is as good as when you're walking in the bright light. So turn the light on, get a night light. These are really simple solutions. Out on the table out there, I have some brochures from the Center for Disease Control. It's called Check for Safety. There's like one in, I think, Mandarin, one in Spanish too, so be sure you get the one in English. And if they're out, you can always go to the CDC website, but they have a lot of good information on modifying your environment. Right, so then there's also physical fall prevention techniques. When we talked about assistive devices, there's not one that's better than the other. It's one that's right for you. Sometimes a family member may be necessary to provide that assistance, to catch somebody from when they're falling. And of course, we're going to get to exercise. So, touching on assistive devices, there's a bunch out there, right? This is just a mere representation going from least to most helpful, right? So trekking poles can work for some people. But that's 2 things you have to keep track of and not trip on. Sometimes even just one pole, just that little point of support. It's like having another little dinky leg. Your dog's balance is much better than yours. So if you're a tripod or quadruped, you're going to be more stable than just on 2. So having a cane is helpful. If you need more help, the walkers can be really useful. The 2 main kinds with the 4 wheels, we have the rollator, and there's one that I have to confess, the USTEP has actually donated one to UC for us to test out with patients. And it's especially designed for people with movement disorders. Big difference, the brakes. Standard rollator, you have to squeeze the brakes to stop. With the USTEP, and I think there are other models like this, you have to squeeze the brakes to go. So it allows you a lot more control. Also, there are a lot more wheels, so it can turn a little bit more tightly. The advanced model has a laser. Yeah, I want to walk with a laser beam. Unfortunately, it's on the floor. Like what? I can't point at cars? No, it's because oftentimes, and this is mainly for Parkinson's, having a visual cue, something to step on or step over, helps drive that stepping. That may be one trick that's also helpful for freezing. If you can unload and go get something, that may help initiate that. It also has a beeper because rhythm, music, keeping in time with that metronome may help drive stepping. And again, a lot of this work is on Parkinson's because that's where the majority of the people are. Okay, but what if your family member needs more help than that? And how do you provide? There's no manual. You don't learn in school, how to help somebody to stand up or how to help somebody out of bed. So this is what I'm here for. Okay, so general rules in providing assistance to someone. First of all, gait belt. We've seen them in the hospitals, little things you kind of snap on. You can use a regular belt. That's okay. Something that is that can be used as a handle. I have to confess, I don't use them all the time, but I'm a trained professional. So, thank you very much. No, but in general, it makes it much easier to handle someone if you've got a really good handle, as long as it's snug and you can use it. Remember that old saying, when somebody's lifting, lift with your legs, not your back. Right? Same thing's true, except now the object you're lifting is really mobile or has a lot more moving parts. Same thing applies. You have to use your whole body when helping somebody move. Also, get them to help. Don't try to power through and do everything yourself. Help your family member by saying, hey, reach for the guardrail. Okay, here we go. 1, 2, 3. Give them time to respond and help you. That's really important. The other big trick, foot placement. You're using your body, stagger your feet in the direction you want somebody to go. If I'm helping someone stand up, I'm not going to be like this, right? I want them to come forward and up, so my feet are going to be here. If they're really stiff and potentially retropulsive, I'm going to be here. So I have one leg to push off of and one leg to go back to. It helps if you've done martial arts for a while, because then you can get down there. So everybody needs to start exercising now to save your backs. It's highly helpful. The other thing too, if you can't do it, get help. Always ask for help. If it's not there, then you can look into getting mechanical devices. It's not worth sacrificing your back because then you can't be helpful to your family member. Okay, the big don't grab them here, because there's, number one, there's a whole lot of nerve bundle right in here that can make your arms zing quite uncomfortably. Also, if you're grabbing here, they can still go down. It's not a really good handle. Again, get help. Don't try to lift more than you can. And don't hurry. How many times have you heard someone fall because, I was just in a hurry, either going by themselves or with help? I forgot to check the brake on the wheelchair. Take time for the setup. Make sure you do that. So, some particulars. Okay, rolling over in bed, right? Trick 2, get their knee bent first. That gives you a nice little handle to roll over. And again, if you're going the other way, you can get your hand under their shoulder blade and slide them backwards. I got a video of this too, so you can watch these. Sitting up and lying down. This is a really challenging one, right? And notice where their knees are, right? They're gotta be bent. How many of you have had a family member who goes into kind of retropulsion when they lie down or try to sit up? They kind of start pushing backwards. That can be really scary on the edge of the bed, right? So if they're here, it's really easy to go slide out. So having one hand at the back in front of their knees to keep them flexed, that can sort of inhibit that extension posturing. And if you need to, do one body part at a time. If they're getting back into bed, help their trunk down first, then bring their legs up. But usually getting up, it's easier to do arms and legs all at once. And you'll see this in the video too. Okay. Sit to stand and scooting. I just noticed that the people in the ergonomics journal did not use a gait belt. But they're holding on to the trunk. Right? And that's the key thing, and that's why I often will choose not to use a gait belt, because I have my whole forearms on their body to help control their trunk. So wherever you can get a solid grip, you're not using your claws so much as your whole body. And again, scooting in bed is pretty tricky. draw a sheet, get a sheet underneath to help them slide up and back. And again, if they're scooting up, step back into it. And then scooting sideways, always help them get their knees bent and have them help lift their butt. Okay. These are pretty basics, but they're important. Okay, so walking. There's a couple tricks to this. Let me see if I can get this going here. There we go. Okay. So if they're still able to walk and you want to go side by side, oh, don't freeze on me. Come on. Why does it always work in the, uh-oh, I've got the swirling rainbow of death. Let's try that. Relaunch. Okay. Oh, that's a song that's really, really funny. And his voice is kind of gravelly, so it makes you want to sing it like the Cowardly Lion. But we digress. Okay. All right. Okay. There we go. Let's try. All right. Let's see if click. Come on. Okay. Oh! Well, you kind of get the idea anyway. Right? Hand one side, hand, oh, for crying out loud. Okay. Let's just try relaunching again. No. Okay. So, main rule, you want to have your hands all in any direction that your family member might go. So if you saw from the picture, or the video, I had my hand all the way around her hip. So I was going to stand on this side, I went all the way around in front. So if they go forward, you've got them sideways, backwards. The other hand was at her hand, or it's going to be in front at her shoulder, so you can catch them if they go forward. Let's try one more time. What? Okay. That's not good. All right, let's try this again. All right. We're just going to skip the skater hold. Okay, so this is the video demonstrating the bed mobility maneuvers. Let me see if I can get it in. Oh. Yes. Cross your fingers. Okay. Gate belt. Okay, so standing up again. And you need to modify your technique depending on what the patient needs. So for example, her right leg tries to buckle. So I have one hand around her body and then I'm going to help support that leg because her tendency is to do that. Also the main thing, if you're being the one, or being the assisted, don't hold on here. You want to have them put their arms around the trunk. Okay. Short video, good. Here is bed mobility. Okay, good. So again, one smooth move, trunk and legs down in one piece. And it's freezing. Again. Okay. This worked fine in a test run. Okay. So you got in there? Okay, I got a thumb drive too. Okay. All right. So again, general rules about mobility are use your body, blocking with your body. I had a video of walking with a patient, and I knew I wanted to tape him because he was having some pretty significant balance problems. He was doing really well that day. I really wanted to demonstrate the bailout, you know, save your family member, because that's when you really need it. If your family member's falling, what do? Do you lower them to the floor? Can you catch them before they go down? And that's kind of a skill that you need to practice and work on. I find it's usually much easier to keep somebody up than getting them up from the floor. So for example, okay, let's see if I can do this. So Dr. T, would you mind being my demo model? Thank you. Forget video, we got live action. What?
I was about to volunteer.
Oh, okay. Well, I figured I needed somebody taller to go, you know, well, I can't, you know, it's easy when they're taller. So if you're here and their knees just bend, so you can clean and jerk him back onto his feet, or you can let go of me. Back up. So even if you go sideways, I've got him. And then you can go, will somebody please get a chair? Well, I try to get him back onto his feet. If that doesn't work, you use your leg as a slide. Step back. I'm not going to make you go all the way down. Now I can slowly go to the floor. Yeah. And you can still save it. All right, but again, my hand, actually he has a gait belt on.
I do.
Yeah.
Very stylish.
Yeah. So that's usually the way that works, is that, again, because I'm using my whole body to block him right here. The other thing you may find is that, could you have a seat, please? So often the tendency may be to lean back. So for example, go ahead and scooch forward, please, a little bit. Thank you. Yeah, this, go ahead and stand up, and then kind of go, so, yeah. Or, nice, show off, sit down. Thank you. All righty. So one temptation is to have your hand way behind their back, and then you're blocking here, but now they have something to push against, so they can actually be leaning on you. So I'll have my hand here, kind of gapping, come forward here, push into my shoulder, push into my shoulder. There you go. And if they get stuck here, oftentimes they get stuck and have a really hard time sitting back down again, right? They can't get that knee bend. You can give them that cue.
Yeah, so you flex my hips.
Yeah, yeah, you just go.
And then you flex them.
Yeah, because that's if they're stuck here and they can't bend, you give them that guide to control their center of gravity. I think that covers it. Thank you very much.
Thank you.
All right, big hand for our volunteer. Here you go. All right. Yes, well done. Let's just skip the remainder of the video because I think we got that one covered. Yes, because we need to get to the exercise part. All right. Okay. Now. Okay. So what if the fall still happens? That's the hard part they do. Take a minute, take a breath, check yourself. Am I hurt? If you are hurt, stay put and call for help. The big temptation, especially if this is out in public, everybody is so uncomfortable with the fact that you fell, they're like trying to get you back onto your feet again. Try to stay in control of the situation. Say, thank you, I appreciate your effort, but please let me say when I'm ready to get up again. Don't let somebody pull you on your feet when you're not ready. And if you're not hurt, then try to get up, but direct the care or direct their assist. Okay. Okay. All right. So getting up, getting onto all fours. Right? So pivot up there. Use a piece of furniture. You climb back up, and then come to sitting. Okay. So because of our technical difficulties, I'm running short on time. These are all in your pictures. So you can refer to these. And I want to thank the MS Society because they have a whole Free from Falls class. So they let me use these slides. Okay. So what you can do to keep your strength, to get moving. gotta keep moving. Use it or lose it is the rule. Problem is, the exercise that's the best for your balance, the most challenging, is also the least safe. Right? There's our drawback. Your balance is awesome lying down. Right? You are not going to fall if you're lying down. Is your balance going to get any better doing lying on your back leg lifts? No. You may be helping stimulate circulation and doing all these good things for your muscles, but it's not going to help your balance. So, try to work on walking safely.
I fell recently, and I was remote from my husband. He found the police whistle.
Good. We'll talk about that more in the question part, but that's a really good tip. The police whistle, right? So the important things is challenging yourself as you can. Phil's wife walked in a harness over a treadmill. You have access to basically some way of supporting that balance so she can still move her feet and challenge her balance. Okay. Everybody always wants to know what the best exercise is. It's the one that you'll do. The one that will do, and if beyond that, the one that will make you sweat. That's it. There's a Tai Chi, there's forced exercise, whatever, do it. What may help is if you focus outside your body, instead of doing just like arm lifts, leg lifts, that's boring. Hit something, throw something, reach for something, right? Go ahead and reach across the table and shake the hand of the person across the table from you, right? If I had more time, I'd make you guys stand up and sit down. Okay, so examples. To flick that towel, you gotta move fast, you gotta move big. That's much easier to move fast and big flinging a towel than you kind of feel like a dork doing that, right? Yeah, that's my mom pulling weeds. Bend, straighten, standing up and sitting down. And you'd be amazed how many mild-mannered people turn into boxing beasts once they get a pair of things on. I also have foam swords in our gym. Those are awesome. You just go to town with those things. Okay, but basic standing exercises. Marching in a corner, or even better, marching in a corner with a chair in front. There's your safety cage. You got the walls, you got the chair. Hold on if you need to. That's okay. If you can do it without holding on, even better. Little toe raises, going walking. All those things as long as you're safe. If that's not safe, then you got sitting. You can all tap your feet and kick your legs right now. Right? Kick, come on. Food coma, kicking in. Let's go. Whoop. Give me 10. Whoop. There you go. Yeah, see? That's not so bad. You can also march. And the big important one right now, everybody off the back of your seat. Sit up tall. Up tall, shoulder blades back. There you go, up tall. Isn't this better? Okay, how about this? Take a big breath in and go, yeah. There you go. See? Easy. Easy. Sit up tall, get your voice working, get your lungs working. Okay, other simple things. Wiping off the counter, punching, moving, right? So, but, there's always a big but, right? Well, but I'm not an athlete. I'm not an exerciser. It's not my thing. You're not a toothbrusher either, but you do it, right? Look at exercise like brushing your teeth. You brush your teeth because why? You want to keep your teeth, right? Don't want cavities. You do your exercise because you want to keep your movement, right? Well, I advanced the slide and I didn't want to. Motivation. It's not fun. It's boring. I have a hard time getting motivated. Get a buddy. Get a lifting buddy. Get a walking buddy. Take a class. There's even Sittercise on PBS, right? Look at your TV listings. Look at the video section. There's all kinds of ways to get somebody on a camera going, get moving. Can't find the time. Can't find the time to be in the hospital either. But schedule it and put it in your schedule. Make a routine. Changing behavior is hard. Make your routine. Give yourself that extra time in the morning after breakfast or at night. Whatever's good for you, plan it. This does not happen on accident. Or If you're sitting and watching TV, every commercial, tap your feet, right? Every time you get up to go to the bathroom, when you come back, stand up and sit down 5 times, right? Simple. Integrate it throughout your day. It doesn't have to be all at once. 10 minutes 3 times a day is good. Sneak it in. Find it. We talked about drive and dementia. All those things, for some people, walking the dog, that may be a great motivator, but that might be too hazardous for some others. Working in the garden could be great, may be too hazardous. That's for you to figure out with your health professional, right? Okay. Also, if you have other medical conditions that may prevent you from exercising, see your doctor, get clearance, see me, see an OT, and if you have to find somebody really good, get a trainer or see your PT and then have them tell the trainer what to do. That's all. All righty. Thank you very much. Yep.
Okay, quite a few questions have already come in. How about getting out of a car?
Yeah, that's a big one, huh? Okay, standing up and sitting down is one of the biggest challenges, right? So, getting out of a car is especially interesting because it's so much lower. Same rules apply, whether it's a chair, the toilet, the car. Lean forward, lean forward, lean forward. Get on the edge of your seat. For example, oftentimes, let me stand for a second. Oftentimes, when people have fallen, they're really timid about moving their center of gravity, right? They want to keep their balance right over with their feet wherever they go. They're not going to lean forward a lot or move. But that's exactly what you have to do. If you're in a car, your weight is back here, and it needs to be over there, right? So it's got to be way in front of you. So get to the edge, get your feet underneath, lean, come forward. If you don't get there in the first try, actually maybe even do a couple warm-ups just for the sake of warming up, especially if you get orthostatic. Getting that movement, getting that blood pumping may help keep your blood pressure up. So you lean, lean, stand, right? Again, can you practice that at home in front of your kitchen sink with maybe a really sturdy chair? Absolutely. Okay, but yeah, that's the big thing, is just getting that lean. If it's really hard, put a cushion in the car seat. Bring the car seat up. Push out against it, or hold on. You can hold on to the door frame and lean. Sometimes turning can be a problem, because you get kind of frozen in there. With freezing, take a breath, lean, step. Often that was a trick devised by John Argue, where he's a theater guy. And you basically find that freezing is a part of not being able to unweight. Right? To take a step, you need to shift your weight to go. But with freezing, you're stuck. Get yourself unstuck, you have to stop going, I'm freezing, and relax, swing, and unweight. Getting that weight shift. That may help turn. If you're turning, lean away and point your foot. If that's in the small spaces, it gets trickier. But holding on to the frame of the car, using any grab bars, and know your car well. They often have grabbers all over the place now where you can lower yourself in safely. But use your hands, raise the seat if you need to. If you have an SUV, get a runner bar. Sometimes it's the opposite problem where it's really high. Get a step stool, get something in there so you can climb up a little bit.
Okay, the next question is, what is your opinion on static versus dynamic balance exercises? And maybe you could explain what those two terms mean.
Great. So, static balance is this. Dynamic balance is, told you I would dance. So we made a bet. Or even dynamic balance is Charleston, right? Where you're moving that center of gravity, right? Which looks like it would be more helpful for getting control of your balance. Yeah, dynamic is really good if you have trouble controlling your balance when you're walking, right? Or if you're controlling your balance when you're walking is so difficult, then this may be where you start. So again, it's a continuum. Both are important. I mean, I had a professor who would argue there is no static balance. Or, yeah, there is no static, because even standing here, everybody sways. You always have a little bit of sway. Just that breathing, just that raising your arms, your center of gravity shifts. So you're always balancing. It's where the optimal challenge is. If you can do those big dynamic ones safely, go for it. My favorite exercise to give people, if it's appropriate for them, is kill the bug, which is this. There's a bug, right? Because what do you need if you trip, if you fall? Speed. You need speed. So trying to move quickly is really helpful. If you're at that level, you can do that. If your joints don't like that, do it in a pool. Try to work on that speed.
Okay, how do you decide on the intensity of exercise?
If they have no other comorbidities preventing them from exercising, no uncontrolled chest pain, no hip in dire need of a replacement, if all other things being equal, you take for cardiovascular exercise, which is usually the general guideline for intensity, take 220, subtract your age. Okay, that's your maximum. Then, that's the ultimate maximum. The limit you want to train at is 80% of that. So 220 minus your age, take 80%, that's the upper limit of your heart rate. Bottom limit, 60, 55, around that range. Take your pulse. There's even an app that can take your pulse from the circulation to your face. I don't know how well it works. But yeah, learn how to take your pulse, right? Yeah, so that's the intensity you want to go with. If that's too hard, if you can walk and still talk but not a normal sentence, you're like, the other day I was going to the store and that's good. You want to be warm. You want to be sweating a little bit. You do not want to be hyperventilating. Okay?
What's the difference between PT and OT, and how do I know which one I need?
Oh, great question. A lot of the residents at UC Medical Center need to know this too. Yeah, we always get walk, walk, talk. It's PT-OT speech. So, we all are, physical, occupational, and speech therapy, they're all licensed professionals. Occupational therapists specialize in activities of daily living. Meaning, can you dress yourself? Can you feed yourself? Can you write a check? Can you figure out how to ride the bus? Can you drive a car? This also means they're really good at adaptive equipment. They're the ones that will give you the long-handled reacher and the adaptive equipment for eating. Of course, you also need to be able to walk to get into the bathroom and stand to brush your teeth. So they also work on that kind of mobility as well. PT works on the key ingredients of that. Can you walk? Can you stand? Can you balance? Can you get out of the house? Can you do things? So we do work very closely together, but OT is more very, very task specific. And then of course we know speech language pathology. We'll learn a lot about it in our next lecture. Their swallowing and cognitive function.
What are good exercises for forward head tilt or side tilt?
Okay. So that's a real challenging problem, especially with PSP. But my favorite, starting where you can get it. Starting where you can get that position. Even if it's lying on your back, tucking your chin into the pillow. You want to think about, because usually it's here. So the problem is too forward. It's forward and collapsing. So you want to be able to lengthen and come back. Using the wall or lying down is a great cue for figuring out how to do that. So for example, if I'm here, I'm going to bring my head to the wall and try to slide that little backwards, occipital protuberance, the part where your skull sticks out, right at the base of your neck. Trying not to use too many technological terms. Keeping your shoulders against the wall and sliding that part up. Once you get this, then you come away and try to stay there. That's really hard. Key thing to remember is not do is, right? That doesn't help. So keeping your neck long. Another trick is putting a book on your head and go back to charm school. Not kidding. I mean, trying to balance something on your head. I've tried that with patients and it's worked sometimes.
Can you talk about forced cycling, an exercise used in Parkinson's disease research?
Yeah, briefly. There's a couple papers on when they have a cycle that actually drives the movement for you. And there's one that argue it's actually the forced use that was better than regular cycling. It can provide a stimulus. I think a lot of it is the fact that it's the challenge to go faster than they can normally. And it's consistent with a lot of what we're finding is that challenge is important, right? If you're being challenged to move faster than you normally can, you get that input, you get that effort. So I think it's not only the type of cardiovascular challenge, it's the motor skill challenge that's important. We find this with our body weight support treadmills too, where I have a Parkinson's patient who walks extremely slowly. We get her in the treadmill and she can step longer, possibly because it's that stimulus.
How about tango therapy or dance therapy?
I'm totally biased. I love ballroom dancing. I love dancing. If you are a dancer and are interested in dancing, they have the key ingredients which are very helpful for any of these problems. It's not dancing per se or boxing per se. It's what those things have. Tango, and there is one paper that compares tango to American-style ballroom, and they both got better, but the tango dancers said they even got more better. The Argentine tango people are so superior. But because I think perhaps it's because of the rotation that you get. But the key ingredients, as I was talking about, rhythm, learning, socializing, challenge, standing up straight, right? This can be in any kind of activity. It's just ballroom or dancing has a lot of those components at once. The other thing is that when you're moving quickly, I mean, the rhythm is driving it, so you're also moving faster than you normally would. So they're key things. I think they're great. I make my Parkinson's patients do Charleston all the time or other things.
What is the best exercise for those with orthostatic hypotension?
That's a really good question, and also really challenging. What I find is that anything to push your blood up to your head, I haven't done a systematic comparison of having somebody do this versus this, or even like leg kicks. Pretty much anything to get your blood going that works big muscle groups. That's going to help push the blood back up to your head. Probably the best example I have was when I was working on acute rehab at CPMC Davies. We had a young man who had a spinal cord injury. And they really get orthostatic badly if they've been in the hospital for a long time. And he had some leg function. But we'd sit him up on the edge of the bed and he'd get lightheaded and try to go down. And he was a martial artist and so was I. So I knew what kind of therapist he needed. He didn't need the soft, sweet approach. He needed, come on, let's go, right? So we had him on the edge of the seat, at the edge of the bed. I said, all right, I want you to lean forward and push against the floor as hard as you can, like you're going to stand up, but don't stand up. Right? So he's going, push, 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 yelling at him. He's pushing hard into the floor, and he shot up. But you're generating that force in your legs, pushing the blood back up to your head. If it's good for the Blue Angels, just thought of that. It can be good for you, right? The Blue Angels are doing all those G's. What do they call it? The herks or something like that? Where they're bracing their legs against the boards of the plane to push the blood back up to your head. So it's generating that contraction in your legs. Take a few minutes and just go push, 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 push. Then try standing up. If you have a home blood pressure monitor, try it out.
Are there any clothes that you can wear or devices such as floor mats that would make falling less dangerous?
Really good question. And there are shorts that have been designed by biomechanists that are basically bike shorts with big pads on either side. So if you do land, because the common landing is going sideways. I took a class taught by Anne Shumway Cook, who's a big leader in the field. And she was holding these things going, I'm not going to wear them. But a big flowy skirt, petticoat, you'll be fine. No, but having the padding on the hips is good. Compliant flooring, that can be a plus or minus. My parents have shag carpet this deep. It is so squishy. It's like walking on a really thick lawn, right? So you can put floor padding in or slightly compliant, but I don't know the exact coefficient of springiness that's optimal, right? Too springy and it's unstable. Springy enough and it can be padded. Marble floor, bad idea. Okay, and always, if you have slippery surfaces, put traction on.
And helmets, for example, do you suggest people wear helmets, or you think that's a bad idea?
If you're falling that frequently, probably a wheelchair would be the better option. But if there's enough cognitive dysfunction where they're getting up and going and falling daily, yeah.
Okay. Is there any exercise to improve handwriting?
Not in particular. However, like any motor skill, you practice what's hard and you practice specifically. So if handwriting is difficult, you get a big sheet of paper and use your whole arm. Use a write-on wipe-off board. Practicing, like framing, making the lines bigger so that you reframe the perception of that amplitude of movement. But yeah, there's no other magic bullet for that than just practice, practice, practice.
My husband takes small steps, little tiny steps. I hate to nag him. Is there anything that you could suggest I can do to improve his safety when walking?
And the step size, yeah. So like I mentioned with the U-step walker or any cues, having targets to step on. There's actually a walker or a cane that has a laser on it. So you can use a laser to step on, and that can help with the step size. The music can also help, practicing marching. But I hate to say it, but we always bark at our patients too. So
Is it better for the PT to bark at the patient than the family member?
Probably. Then you can just say, now remember what Erica said. Big steps, big steps. Yeah, we have a lot of Parkinson's clients in our health and wellness center, and my mentor, Nancy, is louder than me. And that's where I always got it. But you'll hear us always barking, big steps, big steps. So you can quote your therapist.
Can I ask a quick follow-up? How important is hip and ankle mobility for Stryker? Is that an issue that you would recommend people work on?
It's essential. I mean, especially ankle is the key one, because if you don't have dorsiflexion, that pulling that toe up, then it's really likely to catch your foot. So yeah, keeping your ankle stretched, keeping your toes up for that step length. Usually, you only get for normal gait, hip flexion. That takes a lot of restriction to limit that range, because your normal hip range is kind of up here. So there's a lot to lose before that would really restrict that motion. But it is all mobility. Anytime you have a biomechanical restriction, a lack of range of motion somewhere, pain, all that can also contribute to falls. So yeah, all mobility is important, especially like trunk too. Doing any kind of twisting exercise, because again, that normal trunk rotation we get with walking likes to go away.
Can you give me some more ideas on safe, low-intensity, interesting exercises?
Okay. So I had balloons in my bag, but some PTs sneer at that because they're like, oh, it's so juvenile. But being able to hit a balloon. Interesting. Putting music on. Basically standing, if you have a ball, any kind of object, passing it back and forth. Going to get stuff off the floor, turning. Basically any direction you can think of, throwing like beanbag tossing. You can do that from sitting, standing. Tug of war. That's my new favorite. You can play tug of war with the dog. Or what I've been doing lately is putting my clients in a harness, and we have PVC pipe. I'll be on one end, client at the other, and I'll just go, make me move backwards. Now you move backwards. And so now if they're in the harness, they're getting thrown off balance and having to step and recover, but they're in a harness so they can't fall, right? If that's too much, you can always do push and pull in the chair and rotate. And again, if it's really hard to stay engaged, things like sittercise, sit and be fit. There's a lot of videos where you don't have to bark at them. There's somebody on TV doing it. You just have to make sure that they're staying on task.
And by the way, I put together a list of all of the exercise classes in the San Francisco Bay Area, and there's a little tulip, a Parkinson's tulip, next to the exercise classes that are specific for those with Parkinson's disease, and those are probably the one I'd recommend the most for our audience. But there are also adaptive PE exercises. If you check the lonely APDA table in the back corner, which has no one staffing it because I'm up here and Denise is back there and Stephen is over there, so you can check that table. We've got a list back there. Are there any other ideas for motivating an unmotivated, also known as lazy person?
Dynamite.
Dynamite, cattle prod. Yes, rewards. And it has to be something, a reward system, not something they're going to get anyway. Have a pet. Yeah. No, pets are great. I've actually prescribed a dog to 2 people so far. Not for everyone. And I was really worried about doing it because you have to have a good dog that's not going to get underfoot. But there's somebody who needs to be walked every day, right? And it's not you saying, go for a walk. It's Fido going, please. Right? So that's a good motivator. Come on, let's take the walk together. Motivating. It's challenge. That's a really good question. That's when you hire people like me, where people come to your home, and so it's not if you can do it, it's not you barking at your family member the whole time to get moving. You have a professional nag, so they can't say no.
Also, if you have a DVD going with exercise.
Yeah.
What I discovered with my husband who had Parkinson, that if I did it with him,
Yeah.
they don't like to do it by themselves.
Yeah.
But you say, okay, it's 10 o'clock, let's go do our exercises.
Right.
And the 2 of us did it.
Yeah, that's like I said, it's having a buddy, having a partner, doing it together. So it's not, this is something you have to do. You don't have to take your medicine, as we both need it. And believe me, as a caregiver, you're showing what you need to do. If you're going to need help somebody stand up and sit down, you need these leg muscles too, right? You need that power. So it certainly won't hurt you to exercise with them.
My husband has atypical Parkinsonism with dementia. He often gets up without his walker and starts heading across the room, and I'm worried he's going to fall. Sometimes I feel like I'm the one with dementia because I always scream at him and tell him, why don't you remember to take your walker? Do you have any advice?
Oh, yeah. That's a really tough situation. And there's not a, do you have a comment on that?
Yeah, tie a bell to him.
There.
He gets up, the bell rings, you know.
You know, I was thinking about saying that too. I was like, well, that'd be taking the wrong way, but yeah. No, putting a bell, putting something in their pocket so it falls down.
There are also chair alarms and
Yeah.
bed alarms that will go off when somebody
Yeah.
stands up.
And putting the walker like in front of them, almost like, yeah. Yeah, so having it really close to them at all times. That's why I like the U-step walker, is that it's kind of heavy. That can be really helpful because if you set them up, if you go, okay, here's your TV time, put the U-step in front of them, they've got it, it's there. Problem is, and I've had a family report this, if they still have some mobility, they get that sort of moments of freedom. I had one patient family explain that they found their mom on the floor next to the bathroom cupboard with the light cover off and a light bulb in her hand. So she got all the way up on the table, not this one, and was trying to change the light bulb when she froze and fell down. So I'm just, you can set the walker up in front, but there is that risk of just climbing over this thing that's in my way. That's where the bells and the alarms come in handy.
What is the proper way to assist someone in and out of a wheelchair?
Yeah, that's in the pictures where it says the sit to stand. Same thing. There's actually a picture on that slide. There's a picture of the little wheelchair there. The only trick is that you just need to just step and turn with them. What I say is like it's almost like partner dancing. Once you're up and standing, then you may need to rock and step and then sit. And again, if they get stuck, do the good old thumb and the hip flexor may help bring them down a little bit. But yeah.
So what helps then is talking them to it.
Yeah.
Left, right. And other of us that don't get it.
Exactly. Letting the family member help, talking them through, giving them time to process. Okay, now we're going to stand up. Scoot forward. Let them initiate that scooting so they're with you. When you're going to stand up, let them start the stand and then you help from there.
We have time for one more question. Yeah, one more question. This is the last one. What type of exercise do you recommend for someone who sits for long periods of time?
Don't sit for long periods of time. Get up. Next question. Set an alarm. Every commercial, every show change. Stand up and sit down 5 times. I mean, if you're watching the Giants, stand up every time they score, but that may be a whole game where you don't see nothing. So get a cue, get moving.
I'd like to just say a comment that hasn't come up yet, and I found it very important. We had a PT. We thought PT was the best thing we did, along a la Phil Myers and Jackie Myers. We just thought PT and exercise, any form of movement, was wonderful. And my dad had PSP, and with PSP you're unable to look down. And the PT kept drawing a line on the floor and saying, "Step over my foot, step over my foot, step over the piece of tape. What's wrong? Step over my foot." And we had to explain, well, my dad can't look down and his eyes won't voluntarily move down. And so I think it's very important for family members.
Yeah.
You are the people in this room are the most knowledgeable people. It's very rare to find a PT like Erica who knows about these disorders. And so it's your responsibility really to educate the PT, because no one else is going to do it. I just think that's so critical.
Yeah. And it's a hard call because we're geared towards trying to get back. That's what we're sort of trained to do, is restore function. And so a lot of PTs are uncomfortable with the degenerative ones. So we may try in the early stages, if there's that downward gaze palsy. If you can do it once, maybe you can do it again and try practicing that. So again, we go back to our initial slide of that recovery, compensation, preservation. If you still have it, keep doing it as much as you can. But if they really can't, that's when you go towards making the compensatory strategies. Where it may be that you need to, tip your head back in order to see. And maybe getting some sort of support for your neck if you need to position your head in order to see forward. But yeah, it's always that balance between pushing to keep what you have and also having compensatory strategies for when you can't.
That's a very good point. Thanks very much, Dr. Pitch.
Thank you. Thanks for having me. Thank you for participating.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.